This meeting is being recorded.
Okay, noted.
Is 3.5% of the GDP. Nigeria, a nation with a population of over 200 million people, with only 35,000 doctors. That is one doctor to 53,000 Nigerians. The healthcare allocation is 3.5% of the GDP, $5 per person per year. WHO recommends 5%. This explains why our healthcare system is the way it is. Patients are not being attended to. Government hospitals are overcrowded. Health workers are overwhelmed. Private specialists are unaffordable. Something has to be done. To tackle these issues, Health for Nigeria believes the healthcare sector needs an inspired and well-motivated group of young leaders to canvass and act for excellence in the healthcare standards of Nigeria. Our team of healthcare professionals and leaders are committed to improving access to healthcare for all Nigerians, especially our children. With our nurses in all basic schools in Nigeria, we give children basic health education and support across Nigeria. Health for Nigeria, health equity for all Nigerians.
All right, I think we can start now.
When I was a student, I'd write long essays that I'd work on for days. But now I'm writing short emails.
All right, good morning and good afternoon, everyone. So from US, good morning. From Nigeria, the UK, good afternoon. So welcome to another edition of our Health for Nigeria lecture series titled Female Adolescent Health, Puberty and Beyond. So I am Obeolumide Fedayo. I'm the Leadership and Development Coordinator. And without wasting our time, I would like to introduce our founder. He's an associate professor at the University of Maryland and the current commissioner for health at the state of Maryland. That is no other person but Professor Abimbola Akintade. So Professor Abimbola Akintade will take over from here. So we'll talk briefly about Health for Nigeria and what we stand for. And at the same time, we'll bring in our guest lecturer. Thank you so much, everyone. And over to you, Prof. Thank you.
Well, hello, everyone. And once again, thank you very much for taking the time to join us. It is morning here in North America, and I know it's afternoon in the UK and also in Nigeria. Thank you for taking the time. Today, we actually have a very important topic. It's also a very timely topic. But before I talk about that, I just want to talk a little bit about Health for Nigeria. As Mr. Obe mentioned, my name is Ben McIntyre. I'm the founder for Health for Nigeria. And Health for Nigeria, our mission essentially is to try to increase access to healthcare, to primary healthcare for every Nigerian, regardless of socioeconomic status or geographic location. It's been a significant challenge, but also we've actually found ways to make a difference. So we have several different programs through Health for Nigeria. This is one of our programs. We used to have a monthly lecture series, and we thought we were giving too much information, with, not enough time to adequately plan. So we've changed this now to a quarterly lecture series. We have panel discussions. Our flagship program is the Nurses School program, which is what I'll talk a little bit about. Health for Nigeria was founded in 2019. So we're only about a little over 2 years old. And in the last 2 years, we've done quite a lot. With the nurses school program, we actually identify public, secondary, or high schools in rural areas. We partner with the schools. We identify spaces, refurbish those spaces as clinics or sick bays. We hire registered nurses into those spaces, and the registered nurses have 5 primary responsibilities. So one, even though we're still within the thick of COVID, we're transitioning from a pandemic to an endemic. So the nurses work with the teachers, the staff, and the students, teaching them about healthcare promotion, health prevention regarding COVID. The second thing is just a primary first aid. And whenever we encounter situations we can't handle, we transition them to primary healthcare centers. The third thing we do is a health club, so we're not only introducing, but we're fostering knowledge and education of healthcare promotion and disease prevention at an early age for children. The fourth thing we do is for students who we identify have chronic illnesses, we actually go to their homes and we educate their parents and caregivers. And we see that helps the students perform better in school. And the last thing is we go into the community, and identify opportunities to educate, and to screen for diseases such as hypertension and diabetes. And I'm proud to state that even though we launched our first nurses school clinic in the fall of 2020, we're up to 10 clinics, and we have seen over 10,000 children for free. We've also seen now probably over 1,000 teachers and staff for free, and also we've screened also over 1,000 people in the community. So we recognize Health for Nigeria's work is a drop in the bucket in terms of improving the healthcare in Nigeria, but we're really proud to do our part. So just a shout out to the Health for Nigeria staff and the nurses here today. So without further ado, I would like to introduce our speaker, and I am very excited. I hope you are too. I'd like to introduce you to Dr. Tamika Dowling, and I'll just tell you a little bit about her. She has an extensive and very impressive bio. In terms of her education, she got her Bachelor's of Science in Criminal Justice in 2001 from Old Dominion University. She got her Bachelor's of Science in Nursing in 2008 from Norfolk State University. So she's a proud Spartan. She wants everyone to know that. And she got her Master's as a family nurse practitioner in 2016 from South University, and her Doctor of Nursing Practice degree in 2018 from South University. In terms of licensure, when she practiced as a nurse, she worked in the step-down ICU, in the step-down unit, the neuro ICU, the PCU, hepatology unit, endoscopy, and also was a float nurse. As a nurse practitioner, which means she's a provider, her practice includes the emergency care, urgent care, primary care, home health. Dr. Dowling also has her own mobile and telemedicine practice, NP on the Go LLC, where she serves individuals in Florida and Virginia. In terms of teaching, she's also a faculty, which is fantastic. She teaches traditionally and also online in a synchronous and also an asynchronous fashion. She's taught on all levels at the ADN, the baccalaureate level, the master's level. She's taught nurse practitioners and also taught doctoral students. She has her own education business also focused on working with textbook review companies, artificial intelligence, which is the future, mentorship, skills education, and confidence building. In terms of her research and scholarly interests, she's interested in Trichomoniasis vaginalis, which was what her scholarly doctoral project was in 2018. Also women's health and storytelling as a nursing pedagogy in minority nurses. Some of her career highlights include CEU development, to include mentorship and community service. She's an active member of Sigma Theta Tau International and a participating member of the National Council of Negro Women. So please join me in welcoming Dr. Tamika Dowling.
Thank you for that awesome introduction. I appreciate that. All right, so let me get my screen shared so we can get ready to start. All right, so that's me, guys. So this month or this quarterly lecture is going to be about female adolescent health and transitioning through puberty. With respect to the objectives, we're going to discuss puberty. We're going to talk about some puberty changes, emotions, menstrual hygiene. We're also going to illustrate the basic health concepts, summarize self-care concepts. We're going to talk about healthy relationships versus unhealthy relationships. That's very important. We're going to also define consent. We're going to discuss sexual assault and rape, distinguish sexual harassment types, explain contraception, and we're also going to go over sexually transmitted infections, and we're going to dissect teen pregnancy, and then we're going to appraise the impact of nurses and providers overall. So as we start off here with puberty transition, Snyder indicated that there is a transitional period between childhood and adult development. Puberty is complex, it's multifactorial. The process, and it involves genetics, nutrition, socioeconomic, and environmental factors that mediate changes on the psychological and hormonal processes in a systemic manner, ultimately leading to reproductive maturation. Historically, these changes can begin at varying times with varying amounts of time to complete puberty, which culminates in reproductive maturity and fertility. The principal manifestations of puberty include adolescent growth, development of secondary reproductive organs and sexual characteristics, and they also have body composition changes as well. Burns indicated that during the sexual maturity can be divided into 5 stages known as the sexual maturity rating scales. The prepubertal sexual maturity rating goes from SMR 1 to adult SMR 5. Breast development you can see in stages 1 through 5. So this is a term that we learn about with respect to Tanner staging. In Tanner 1, pre-adolescent, you're not going to have any growth or pubic hair. Tanner 2, it's going to be scarcely pigmented, straight hair along the medial line. And in Tanner 3, there's going to be some sparse, dark, visibly pigmented, curly pubic hair on the labia. And for Tanner 4, the hair becomes more coarse, more curly, it's more abundant. However, it's still less than what you see in an adult. Tanner 5 is when we get the lateral spreading type and triangle spread on the adult hair to the medial surface of the thighs. The important thing to understand is these factors are dependent on ethnicity, socioeconomic, and nutritional factors with respect to overall timing. So with respect to puberty changes, Burns indicated that the changes in the female body composition occur during puberty, and they benefit from reassurance from the family and from the pediatrician. Initial breast development usually begins as a unilateral disc subareolar swelling. Some adolescents and their parents can have concerns about breast tumors, and it's not uncommon for girls to have asymmetry in their breasts, and they just require some reassurance. Breasts typically will become the same size within a few years. The body changes with respect to the hips and thighs. The young girl will experience a continuous increase in proportion of fat to total body mass during the transition of puberty. Upon entering puberty with approximately 80% of lean body weight and 20% of body fat, at the end of puberty, the lean body mass drops to about 75%. It's important to understand that body fat is an important mediator of the onset of menstruation and having regular cycles. Burns also reported that females who develop secondary characteristics that we discussed earlier than their peers are at increased risk for sexual assault, sexual abuse, dating violence, psychosocial issues, and depression. So I have an overview for you here for the understand the process of puberty.
Long time ago, in a uterus far, far away, there was a sexually undifferentiated embryo that could develop into either a male or a female according to its sex chromosomes. During that time, most of its organs and systems took shape and started functioning. But one system, the reproductive system,
Dr. Dowling, we can't see the video.
Kick into action.
Oh, I'm sorry.
Even
We're
though
only
we're
seeing
born
your
with
slide.
differentiated male or female sex
Okay,
organs,
hold up.
it's not until puberty.
I'm gonna come out. The screen share. There we go. Can y'all see that now? Good, okay.
Far away, there was a sexually undifferentiated embryo that could develop into either a male or a female according to its sex chromosomes. During that time, most of its organs and systems took shape and started functioning. But one system, the reproductive system, developed and then waited for a trigger to kick into action. Even though we're born with differentiated male or female sex organs, it's not until puberty that they are fully mature, and that's when an individual becomes capable of reproduction. Sexual maturation is under the control of the hypothalamic pituitary gonadal axis. The hypothalamic pituitary gonadal axis is a system of hormone signaling between the hypothalamus, pituitary gland, and gonads, either the testes or ovaries, to control sexual development and reproduction. Gonadotropin-releasing hormone, or GnRH, is released into the hypophyseal portal system, which is a network of capillaries connecting the hypothalamus to the hypophysis, or pituitary. When gonadotropin-releasing hormone reaches the anterior lobe of the pituitary gland, it stimulates cells called gonadotrophs to release gonadotropin hormones, luteinizing hormone, or LH, and follicle-stimulating hormone, or FSH, into the blood. These gonadotropin hormones then stimulate the gonads to produce sex-specific hormones, which are estrogen and progesterone in females, and testosterone in males. Now, the amount of hormone that gets produced by this axis varies over a person's lifetime, and that affects the development of the sex organs, as well as the appearance of secondary sexual characteristics. GnRH secretion begins during week 4 of intrauterine life, and the pituitary starts secreting FSH and LH between weeks 10 and 12. But after a mid-pregnancy peak, levels of these hormones drop. Once the baby is born, secretion of GnRH, FSH, and LH continues, but the levels remain low throughout childhood, with the FSH level being higher than the LH level. Puberty begins when a part of the hypothalamus called the pulse generator, or the tonic center, begins secreting GnRH in, well, pulses, sometimes secreting a little bit more GnRH and sometimes a bit less. The pulse generator starts doing this between age 10 to 14 in females and age 12 to 16 in males. Pulses of GnRH lead to pulsatile secretion of LH and FSH. At first, large LH pulses occur at night during the REM phase of sleep. As puberty advances, both LH and FSH pulses start happening during the day. Over time, they become more frequent. Also in puberty, the GnRH receptors in the anterior pituitary become more sensitive to GnRH stimulation. So a small increase in GnRH leads to a large increase in FSH and LH levels. In some, these changes lead to a change in the FSH to LH ratio, with LH levels becoming higher than FSH. The pulsatile secretion of FSH and LH causes the gonads to produce sex hormones and gametes, sperm in males and oocytes in females. In males, the pulses of FSH and LH act on the Leydig and Sertoli cells in the testes. Leydig cells respond to LH by producing testosterone, while Sertoli cells respond to FSH by kickstarting the production of sperm. In females, FSH and LH act on the ovarian follicles, which are scattered inside the ovaries. Each ovarian follicle is made up of a ring of granulosa and theca cells surrounding a primary oocyte at its core. Theca cells respond to LH by producing androstenedione, an androgen. Then the granulosa cells respond to FSH by converting the androstenedione into estrogen and progesterone. However, in the female hypothalamus, there's also a region called the surge, or cyclic center, which makes FSH and LH levels vary over the menstrual cycle. The menstrual cycle lasts 28 days on average and is centered around a surge of FSH and LH happening on day 14, which makes ovulation possible. At ovulation, the primary oocyte develops into a secondary oocyte, the female gamete, which is released from the ovarian follicle into the fallopian tube, where it can be fertilized by a sperm. These variations in FSH and LH levels result in fluctuating levels of estrogen and progesterone that vary according to the phases of the menstrual cycle. 2 weeks before ovulation are called the follicular phase, during which the granulosa cells produce mostly estrogen. The 2 weeks following ovulation are called the luteal phase, during which the granulosa cells produce more progesterone instead. The increased production of sex hormones drives the development of primary and secondary sex characteristics in both sexes. Primary sex characteristics refers to the genitals, which are the organs directly involved in sexual reproduction. Secondary sex characteristics refers to any sex-specific physical characteristic that's not directly involved or necessary in sexual reproduction, like the growth of pubic hair in both sexes, the deepening of the voice in males, and the development of breasts in females. These characteristics can be evaluated with the Tanner scale, which represents a predictable set of steps that males and females go through at puberty as they develop primary and secondary sex characteristics and become more sexually mature. The Tanner scale centers on 2 independent criteria: the appearance of pubic hair in both sexes, the increase in testicular volume and penile size and length in males, and breast development in females. There are 5 stages. In stage 1, the prepubertal stage, no pubic hair is present in either sex. Males have a small penis and testes, and females have a flat chest. In stage 2, soft pubic hair appears. There is a measurable enlargement of the testes, and breast buds appear. In stage 3, pubic hair becomes coarser, the penis begins to enlarge in both size and length, and breast mounds form. In stage 4, pubic hair begins to cover the pubic area, and penis begins to widen, and breast enlargement continues to form a mound-on-mound contour of the breast. In stage 5, pubic hair extends to the inner thigh, the penis and testes have enlarged to adult size, and the breast takes on an adult contour. All right, as a quick recap, during puberty, the sex organs mature functionally and begin producing sex hormones and gametes. Puberty begins when the hypothalamus and the pituitary switch from a linear pattern of GnRH, FSH, and LH secretion to a pulsatile pattern. In addition, in females, there's also a 28-day cycle of gonadotropin secretion called the menstrual cycle. The increased production of sex hormones determines the development of primary and secondary sex characteristics in both sexes, and these characteristics can be evaluated with the Tanner scale.
Okay, so I like being able to give individuals the audio-visual portion of it. I think that helps augment understanding. So here we are, emotions. All right. So during this transition, there are rapid physical changes in early adolescence that can often lead to an increase in self-consciousness, and young girls begin to focus on their external characteristics. Young girls can feel that everyone is looking at them, and they begin to question themselves. Is their appearance normal? As the healthcare provider, we want to make emphasis on the young patient that each individual develops through puberty in the same sequence, but at their own pace. Encourage parents to monitor self-esteem. Ask your kids about their moods. Them having mood lability is normal. change in moods. We want to also assess for excessive stress and depression. Also, while discussing emotions, a reminder to ask about physical, emotional, and/or sexual abuse. It is important to discuss the use of social media, online social networks, and to remind the patient about sharing their personal information, photos, and videos, regardless if it is on the internet or the phone. In my clinical practice, I make it a point to discuss not sharing your location, your state, your city, photos, especially if someone is asking for photos of body parts. And a reminder about the internet, once it's out there forever. So we're moving on to menstruation hygiene. So pads. Pads can come in different sizes: super, slender, overnight, maxi, mini, and scented. Some young ladies have heavier bleeding with their menstruation cycle, and others may have light bleeding. The pad will vary by size and absorbency. It's important to find the right pad that does not have leakage. Some pads can have deodorant on them. However, it is important to understand that the deodorant and the pad can be irritating to the skin. Pads should be changed every 3 to 4 hours, even if the flow is light. This helps prevent the buildup of bacteria. It still is a moist environment, and bacteria grows in a dark, moist environment. Also, changing every 3 to 4 hours can decrease odor. If the flow is heavier, you want to change the pad sooner. So you have disposable pads. Most pads have a sticky strip along the bottom. You peel off the paper strip that covers the adhesive and press the pad into the crotch of the underwear. If the pad has wings, then you will wrap these around the bottom of the crotch of the underwear. To remove the pad, unstick it from your underwear and wrap it in toilet paper. Put it in the trash can or in a special disposal box that's found in most bathroom stalls. Don't try to flush the pad down the toilet, because the toilet can become clogged and it will make a big mess. There's also reusable pads. These pads are washed after every time you wear them. They're sold in natural health stores and online. These kinds of pads snap or clip onto a young girl's underwear. Girls might use these pads because they feel better for the environment or to save money. It's all a matter of personal preference. All right, so tampons. Tampons absorb blood from inside the vagina. A tampon is also made of absorbent material, but it's compressed into a small tube. Tampons come in different sizes and absorbencies for heavier and lighter periods. Tampons can come with or without deodorant. There is no need for deodorant in the tampon because changing tampons regularly usually gets rid of any odor. The deodorant in tampons can irritate the vagina, and some could actually cause an allergic reaction in young girls. Some tampons come with an applicator. An applicator, it can be plastic or it can be cardboard. And then some come without an applicator, and those you would insert into the vagina with your finger. So with tampon use, the tampon is put into the vagina using an applicator or finger, and afterwards wash your hands. It is important to change the tampon every few hours. Change the tampon every 4 to 6 hours. Tampons have a string attached that stays outside of the vagina. So to remove it, simply pull on the string until the tampon comes out. Wrap it in toilet paper and throw it in the trash. Even if it says that it's flushable, it can still cause plumbing problems. The tampon will not get lost in the body. The cervix is at the top of the vagina and it's too tiny for the tampon to get through. Never leave a tampon in all day or all night, even for light cycles. Doing so can put one at risk for toxic shock syndrome. What is toxic shock syndrome? It's a life-threatening condition that is caused from the release of toxins from an overgrowth of bacteria, and it could be fatal. And so menstrual cup. So similar to a tampon, it's inserted into the vagina, but instead of absorption, the cup catches the blood before it flows out of the vagina. The cup is flexible. It depends on your preference. And it's important to understand that even though the cup, it may look like a diaphragm to some, but it does not prevent pregnancy. So understanding health. Let's talk about hand washing. So with the hand washing, we can do cold to warm water. You want to wet your hands, use soap, lather for 20 seconds, wash between your fingers, under your nails, your hand, and your wrist, rinse and dry. When do you wash your hands? You're going to wash them before you eat, before you cook, after you use the bathroom, after you clean around the house, after you touch your pet, before and after visiting or taking care of sick people, after being outside, after blowing your nose, after coughing or sneezing, after handling mail or packages. If you don't have soap, you can use hand sanitizer. Germs spread from dirty hands, contaminated food or water, changing dirty diapers, droplets from cough, sneeze, and contact with sick individuals' body fluids. Let's talk about vaccines. So immunization should be given according to the recommendations set by the immunization schedule, such as the CDC. Why should an individual get vaccinated? It's important to understand that vaccines do not just protect one in childhood, but as an adult as well. For an example, mumps can actually cause infertility. Hepatitis B attacks the liver. And the HPV vaccine can protect against conditions such as cancer. With respect to vaccine safety and side effects, your provider can discuss this with you and provide you with a written handout for review. So some different schedules for you to review would be hepatitis B, measles, mumps, rubella, the tetanus toxoid, varicella, meningococcal, which gives you protection from meningitis, human papillomavirus, the trade name for that vaccine is called Gardasil, influenza, coronavirus. The vaccines I mentioned are anticipatory guidance for adolescents, young girls. However, I will provide a link in the chat from birth to adult for your review at the end of the presentation. And so medical tests. From your blood, your provider can tell a lot of things about what's happening in the body. With the spirometry, they can actually measure the strength of your lungs and help you with managing conditions like asthma. Also, X-rays and CT scans can take picture of what's going on inside of your body, but it does not hurt. I do have a video, and I'll put that in the board as well. It's just a small little video that shows kids what to expect when they go to get phlebotomy, which is getting some blood drawn. It's very, very simple and quick. So let's talk about infectious versus contagious. So infectious diseases are caused by germs such as bacteria or viruses that can get into the body and cause problems. Infectious diseases that spread from one person to another is said to be contagious. An example of something that's infectious but not contagious is Lyme disease. This is not spread person to person. This is from an actual insect to a person. But things that are contagious, examples include flu, colds, strep, mononucleosis. And how can you get some of these things like strep and mono, kissing, sharing cups, straws, and then also sexually transmitted diseases are spread from sex, oral, anal, or vaginal. This is why it's important to use condoms. Communication with your provider. So your provider could be doctor, nurse practitioner, PA. You want to ask questions, and you can actually write them down before going to your appointment so that you can remember what you want to ask, because sometimes you get to your appointment and you forgot what you wanted to talk to your provider about. It's important that we teach young girls about wellness, illness, and how to advocate and manage their care. So let's talk about self-care. So the skin, all right, especially with puberty, acne. Acne is a normal occurrence in puberty. This condition can cause bumps on the skin. Some of the bumps are known as blackheads, whiteheads, pimples, and cysts. This occurs due to hormone changes. Hair follicles or pores and skin make oil. During puberty, hormone stimulations make the sebaceous glands make more oil. How can we prevent acne? So you can wash your face 1 to 2 times daily with a mild soap and warm water. I particularly use Dove unscented mild soap for my skin. You don't want to scrub your skin hard with a washcloth. If you use makeup or sunscreen, make sure it's labeled non-comedogenic or non-acnogenic. If you use hairsprays or gels, make sure you spray that away from your face. And then over-the-counter agents that contain salicylic acid and benzoyl peroxide can actually help prevent acne. So exercise. All right, so exercise. Experts recommend for teens to get 60 minutes of moderate to vigorous exercise daily. So exercise can benefit the body and mind. The chemical releases help you feel good, sleep better. It decreases chances for depression and anxiety, and it provides an overall sense of accomplishment. Exercise also helps to keep a healthy weight, preventing type 2 diabetes, heart disease, and hypertension. Exercise can also help a person age well, improve the quality of life, and can help improve brain health and decrease chances of brain disease that can cause memory loss. Some different types of exercise include, so you got aerobics, Zumba, basketball, soccer, lacrosse, hockey, rowing, biking, running, swimming, dancing, skating, tennis, skiing, hiking, and even a brisk walk. All right, so let's talk about rest. Most teens need about 8 to 10 hours of sleep each night. Getting the right amount of sleep is important for anyone who wants to do well on their tests and do their best in sports. During the teen years, the body's circadian rhythm, which is an internal biological clock, is reset, telling a person to fall asleep later or wake up later. This change is likely due to the brain hormone melatonin, which is released later at night for teens than it is for kids and adults. This can make it harder for teens to fall asleep early. Changes in the body's circadian rhythm coincide with a busy time in life. For most teens, they have pressure about doing well in school. It's more intense and it gets harder, and they have to have a lot of studying. Teens have other time demands, everything from sports and other extracurricular activities, and even working a part-time job. Let's not forget using electronics, including phones, tablets, and computers. That makes it harder to fall asleep. Many teens are up late texting friends, playing games, and watching videos. Early school start times may also play a role in lost sleep. Teens who fall asleep after midnight still have to get up early for school, meaning they might squeeze in only 6 or 7 hours or less of sleep at night. A few hours of missed sleep may not seem like a big deal, but it can create a noticeable sleep deficit over time. Okay, so what's the reasons for getting proper rest? We want you to be able to pay attention in school, proper athletic performance, normal growth and development, and being healthy overall. So what are some strategies? Exercise regularly, turn off electronics, avoid caffeine, don't take frequent naps, create the proper sleep environment. How can you do that? So you can do a dark room, nature sounds, or white noise. I particularly like to put on the sound of rain or the ocean when I go to sleep. All right, so let's talk about safety. Tips for driving safety. So we want to make sure we're avoiding distractions such as looking at cell phones, text messaging, or even turning the radio dial. Always call home if you do not feel safe to drive or if you do not feel safe driving with someone. Call home if you are going to be late. Always wear your seatbelt. Obey the traffic laws. Never speed. Don't tailgate. Don't cut others off. Never drive under the influence, alcohols, drugs, or even prescription medications. Always tell parents who you are riding with. So some of the substances that parents and providers should be cognizant about and talk to their children about, we want to talk to them about alcohol, anabolic steroids, cocaine, depressants, benzodiazepines such as Ativan and Xanax, marijuana, tobacco, gasoline sniffing, hallucinogens, vaping. We also want you to talk to your teen about peer pressure and consequences. Talk to them about the effects of and the impacts of having an impaired judgment, reasons why they should avoid the different substances that we just discussed. So healthy relationships. First, the parent is the primary source of information to the child for guidance in matters relating to sex, sexuality, love, and dating. When the teachable moment presents itself, this is the time to have the talk with your child. Adolescence can be tough to get through without questions of sex, sexuality, and sexual identity, but adolescents are human too. No matter how alien they may seem to their parents at times, openly addressing all too human questions of sexual development, sexual desire, and the nature of adolescents developing sexual identity are critical. Sharing factual information with and giving good moral guidance to your teenager is a vitally important part of helping your teen understand herself or himself. It can help your child avoid devastating and possibly life-threatening errors in judgment. So let's talk about coming out, information for parents of LGBTQ teens. Coming out is a lifelong journey of understanding, acknowledging, and sharing one's gender identity and or sexual orientation with others. It may be quick and easy for some, and it could be longer or more difficult for others. It's important for parents of lesbian, gay, bisexual, transgender, and questioning teens to remember each child is unique and will have their own experiences and feelings along the way. I feel different from other kids, they might tell you. Feelings of being different emerge throughout childhood, although it may not be clear to the child what the feeling means. Children may begin exploring gender and relationships before kindergarten. So coming out and sharing these feelings of being different with others may happen at any time. For many kids, gender identity becomes clear around puberty as they develop gender characteristics and strong romantic attractions. However, many LGBTQ teens have said in retrospect that they begin to have some sense of feeling different about themselves early in life, and for gender diverse youth, some as far as back as preschool. It is common for LGBTQ teens to feel scared or nervous during this stage. Some can start to feel isolated from their peers, especially if they feel they don't fit in or they're being given a hard time for being different. Just remember that children who feel loved and accepted for who they are have a much easier time in life. Parents and families can play an important role in advocating for safe spaces while their children can explore interests with judgment or stereotypes. Support diverse friendships and social involvement without focusing on expectations around gender. And they can engage in conversations and chat regularly with their children about their interests, friends, groups, romantic attractions, and bullying or teasing that may take place. So, what to expect in deciding to wait? Let's talk about that. How do I know if I'm ready to have sex? No matter what you've heard, read, or seen, not everyone your age is having sex, including oral sex and intercourse. In fact, more than half of all teens choose to wait until they're older to have sex. If you have already had sex, but you are not unsure if you should again, then you should wait before having sex again. New feelings. Being physically attracted to another person and trying to figure out how to deal with these feelings is perfectly normal. Kissing and hugging are often accompanied by really intense sexual feelings. These feelings may tempt you to go all the way. Before things go too far, try asking yourself the following questions. Do I really want to have sex? Is this person pressuring me to have sex? Am I ready to have sex? What will happen after I have sex with this person? Remember, you can show how you feel about someone without having sex. You can still be abstinent with him or her. Can you be sexual without having sex? Yes. Being sexual can mean spending romantic time together, holding hands, kissing, or cuddling. Questions to ask. Are you ready? Ask yourself the following questions. How do you feel when you are with this person? Is this person kind and caring? Does this person respect you and your opinions? Have you talked together about whether or not you want to have sex? Have you talked about using condoms? Have you talked about sexually transmitted infections? Have you talked about pregnancy? Will you stay together after you have sex? Is this person going to go back to school and tell everyone that you did have sex? So expect respect, healthy relationships. A sign of a healthy relationship is respecting each other, knowing that you can make each other better people, sharing common interests, but having outside friends and outside activities outside of the relationship. You can settle disagreements peacefully and with respect. Relationships are supposed to make both people feel happy. People should feel good about what happens when they are together. Respect. You can each ask each other what you want to do. No one tries to control the other person. With respect to common interests, you enjoy doing things together, but no one feels forced to do anything. If you have a disagreement, and it's okay to disagree, you both get to say what you want, talk until you're both happy, and then go out and enjoy what you've planned. Being with each other or being apart. You enjoy each other's company and feel happy when you're together. You each feel free enough to still have your own friends and have outside interests outside of the relationship. All right, so let's talk about unhealthy relationships and signs and symptoms. So some of those could include lying, cheating, jealousy, and disrespect. Someone's trying to control their partner. That includes keeping track of where you're going and why you're going to go hang out with that person, checking your phone, checking your email without your permission, keeping you away from your friends or family, telling a person what activities they can do, preventing them from actually having money. What are signs of an actual abusive relationship? Anyone can find themselves in an abusive relationship, no matter the age, the gender, or sexual orientation. Movies and TV shows depict abuse might give you the impression that an abusive relationship is only when someone is getting hit or physically hurt. But there are different types of abuse that can affect your body, your emotions, and your self-esteem. So physical abuse means hitting, kicking, pushing, or hurting someone. Sexual abuse is forcing your partner to do anything sexual, from kissing to having sex when consent has not been given. Verbal abuse is name calling, put downs, using words to actually hurt someone. Emotional abuse is when your partner tries to make you feel bad about yourself. That means they could be hurting your feelings on purpose, jealousy, blaming you for the actual abuse or for them cheating or continually criticizing you. Emotional abuse will affect self-esteem. Reproductive control is pressuring your partner to get pregnant or to end a pregnancy or lying about birth control. Threats and intimidation, using the threat of violence or abuse to control a partner. Threatening children, suicide, or physical violence are also ways to control your behavior. Isolation is this person controlling who you see, what you do, and limiting your access to your family, your friends, and your different forms of emotional and financial support. How do you get out of an abusive relationship? If you're in an abusive relationship, know that you're not alone and that you deserve better. If your partner hurts you physically, emotionally, or sexually, remember, nothing you said or did justifies this behavior. Everyone gets mad sometimes, but talking things through is the way to deal with problems, not hurting you or putting you down. Abuse doesn't happen because you did something wrong or weren't good enough to prevent it from happening. Domestic abuse happens because someone made a choice to manipulate and control you to make themselves more powerful. Remember, you deserve healthy, happy relationships. Abuse of any kind is never okay. When you break up with an abusive partner, it's important to have a safety plan. If you're afraid that they might hurt you or your children or other people you love, you can call the National Domestic Violence Hotline, and I have the number up there for you. So let's talk about consent. So consent is agreement to participate in a sexual activity. Before being sexually active with an individual, it's important to understand that they want to participate with you. You have to be honest with your partner about what you want to do. Consenting and asking for consent are all about personal boundaries and respecting the boundaries of your partner. It's important to check in and make sure that things are clear. Both people have to agree to the sex every single time for it to be consensual. Without consent, sexual activity, including oral sex, genital touching, vaginal or anal presentation, is sexual assault or rape. Freely given. So consent is a choice you make without pressure, manipulation, or under the influence of drugs or alcohol. Reversible. Anyone can change their mind about what they feel like doing at any given time, even if you both are naked. Informed. You can only consent to something if you have the full story. For example, if someone says they'll use a condom and then they don't, this isn't full consent. Enthusiastic. When it comes to sex, you should only do stuff you want to do, not things that you feel you're expected to do. Specific. Saying yes to one thing, like going to the bedroom to make out, doesn't mean you said yes to having sex. You get the final say over what happens with your body. It doesn't matter if you've hooked up before or even if you said yes earlier and then changed your mind. You're allowed to say stop at any time, and your partner needs to respect that. Consent is never implied by things like your past behavior, what you wear, or where you go. And sexual consent has to always be clearly communicated. People who are drunk, high, or passed out cannot give consent. I do have a short little video here. Let me stop. Come back. That is sharing that screen, hopefully. Okay, did y'all see that change where it says, how do you know if someone wants to have sex with you? Okay, good.
How do you know for sure if someone wants to have sex with you? Well, actually, there's only one way. They need to tell you. You need to have consent. But what does consent really mean? Consent means both parties are really, truly into what's going on. This means that nobody's being guilted or pressured into doing anything. Silence does not equal consent. Some people think it's not rape unless there's fighting, screaming, or someone yelling no, but that's not true. Communication doesn't always happen with words. Body language can say a lot if you pay attention. Are they leaning in or are they pulling away? Do they look happy or do they look uncomfortable? Are they kissing you back or are they just staying kind of still? You have to pay attention to all the signals. This includes body language and words. No one can read minds, so it's always good to talk about it. Asking for consent doesn't have to be awkward. Asking for consent can actually be kind of sexy.
Want to show me your bedroom?
Show me where you want me to touch you.
Do you want to help me take these clothes off?
So, let's break this consent thing way down. 1, everyone's clear about what's about to happen next, and they're happy about it. If you're making out with someone for the first time and you want to go further, check in first.
Can I take your shirt off?
Want to try something different?
2, everyone in the situation has to feel free to be able to say no without being pressured or hassled. It's not cool to pressure people into doing stuff they're obviously uncomfortable with, or make them feel bad for saying no or wanting to stop things. Being pushy or manipulative makes for some pretty bad sex. And obviously, if a person is drunk, high, passed out, or asleep, it's not okay to do sexual stuff with them. They can't consent when wasted or unconscious. So doing this is actually rape. 3, be honest about whether or not you're on birth control, have an STD, or having sex with other people. Wouldn't you want to know that? If you're going to get naked with someone, you have to have trust and honesty. 4, saying yes to sex once doesn't mean you're saying yes to it forever. It may be tough to pause in the middle of some super sweet action, but your partner has the right to stop at any time. And 5, sex is all about connections and pleasure, right? If everyone feels respected, sex will be much better for both of you. We all deserve a safe, pleasurable, and awesome sex life. The more respect you show to the other person, the more they'll trust you enough to relax and enjoy. And the more honest you are about what you want and don't want, the better things will go. It's easy to talk about what consent means, but what does it look like in real life? How are we supposed to know for sure how far someone wants to go or if they want to get intimate at all? Check out our other videos for tips on how to do this consent thing right.
All right, so we are on sexually transmitted infections. We talked about Hep B and the HPV vaccine already, but abstinence is not having sex, right? We're not going to get any sexually transmitted infections if we are being abstinent. We also can have a reduction on the number of partners. This can decrease the risk for sexually transmitted infections. However, it is important that you and your partner get tested and share results with one another. Mutual monogamy. This means that you agree to be sexually active with one person and they have agreed to be only sexually active with you, and still the same. You both should get tested and share your results with each other. Correct and consistent condoms use is highly effective in reducing STD transmission and should be used with oral, vaginal, and anal sex. If there are latex allergies, there are synthetic condoms. Natural membranous condoms are not recommended for STD prevention. These would be the lambskin condoms, and those types of condoms help prevent pregnancy. Chlamydia and gonorrhea are infections that can be cured. The CDC does recommend that women that are sexually active that are 25 and under with multiple sex partners should be tested annually. And then we want to also make sure that everyone understands that there is a growing antibiotic resistance to gonorrhea. However, it can be cured with the right medication. With respect to genital herpes, there is no cure. There's a retroviral medication that's available that can reduce the symptoms and reduce spread to your partner. With respect to hepatitis A, this is usually with contaminated food and water. It can still be transmitted sexually from person to person from fecal oral contact. Treatment is supported for those that experience acute liver failure. Vaccination is the most effective means of preventing hepatitis A transmission. And typically this vaccine is administered during childhood. The highest amount of hepatitis B is actually found in the blood, and there's lower concentrations in body fluids such as wound exudates, semen, vaginal secretions, and saliva. Hepatitis B can be limited or it can be chronic. The strategy for the CDC with eliminating transmission includes prevention or perinatal infection through routine screening of all pregnant women, routine infant vaccination, vaccination of previously unvaccinated children, and vaccination of high-risk groups. High-risk groups include individuals with multiple sex partners, those that use injecting drugs, men having sex with men, and treatment is supportive. Let's see, with hepatitis C, this is the most common chronic bloodborne infection in the United States. Sexual transmission of HCV can occur, especially in individuals that are co-infected with HIV. Chronic infection occurs in about 75 to 85% of individuals. It can be transmitted through sharing needles and tattoos. There are regulations in place now with respect to the tattoos. Hepatitis C is curable and persons diagnosed should be referred to an actual hepatologist. HIV can be spread through sexual contact, and it is a bloodborne pathogen as well. You're at increased risk when having sex with multiple partners, having anal, vaginal, oral sex, having anonymous sexual partners, and having sex while under the influence of drugs and alcohol can lower one's inhibitions, which can result in greater risk taking. To prevent, choose less risky activities, use a new condom for every activity consistently and correctly, and reduce the number of sexual partners, no alcohol or drug use during sex, and talk to your healthcare partner about being tested. So pelvic inflammatory disease, what is that? That's an infection of a woman's reproductive organs. Sometimes a complication of an STD like gonorrhea, but not limited to chlamydia. Typically, the STD was present and it did not get treated, and it spread up into the woman's uterus. Also, having multiple sex partners, IUDs, and douches can increase risk factors there. It's important to be seen and let your provider order the appropriate diagnostics and ensure that the adequate treatment is ordered for the pelvic inflammatory disease that's caused by chlamydia, gonorrhea, bacteria-based conditions. This is definitely curable. Again, you do want to make sure you get the appropriate diagnostics and make sure that something's not present like an actual abscess. Syphilis is spread by direct contact with a syphilis sore during vaginal, anal, or oral sex and can be spread during pregnancy as well. Understand that the sore can be in a place that the condom does not cover, and it can still be transmitted. There are multiple stages, 4 stages to syphilis. In the tertiary stage of syphilis, this is when it has hit the nervous system. The condition itself is curable, but once it has done damage to different body systems, that damage cannot be repaired. So trichomoniasis, this is a very common sexually transmitted infection. It's caused by a protozoan parasite. Symptoms can vary, but it can cause infection to the vulva, the vagina, the cervix, the urethra. And during pregnancy, this can cause premature rupture of membranes, and it can also cause low birth weight in the child. Because this particular sexually transmitted disease is very inflammatory, a lot of inflammation, it is easier for an individual to get infected with HIV in the presence of this particular sexually transmitted disease. This is curable with antibiotics. All right, so birth control and contraception. So abstinence is the most completely effective methodology with respect to pregnancy and sexually transmitted diseases. My grandfather used to call me Poopsie, and I recall him saying, "Poopsie, what is safe sex?" I was in junior high at the time, and I began to tell him about barrier methods that I had learned about. And his response said, "No, safe sex is no sex. Wait until you're married." So the male condom is moderately effective, and it does provide protection against STIs. The female condom is less effective for protection against pregnancy, and it does provide some protection against STIs. So with respect to all these other things here, so you got your oral contraceptives, you got your IUD, you got your injection, your NuvaRing, your emergency contraception, your patch, your diaphragm. All of these different things that I just named, they can help give you protection against becoming pregnant, but they do not protect you from sexually transmitted diseases. The spermicide is even less effective at preventing pregnancy, and it doesn't really provide that much protection against sexually transmitted diseases. The withdrawal method is less effective at preventing pregnancy, and it offers no protection at all for sexually transmitted diseases. And sex without birth control, I mean, it's not effective at preventing pregnancy at all, and it does not offer any protection against STDs. As a provider, when I discuss contraception with my patients, I've collected adequate history on the social aspect of their life, and I can make recommendations according to their responses. For example, if someone is in multiple relationships and they are healthy, they can take, the pill, the patch, injections. However, I'm going to drill it into the education that they still have to use a condom every time to prevent sexually transmitted infections, since the aforementioned options, as I illustrated, don't give protection from sexually transmitted infections. Now, if a married couple presents, they have multiple children, the wife is expressing she does not want to have any more children, and she's still having a menstrual cycle, one probable option for her could be an IUD. She could do the Mirena or the Kylena, and they're effective for 5 years, or Skyla, which is effective for 3 years. Talking to your patient about their different options, and I like to give brochures and pamphlets of information to them as well. That helps augment understanding when you have that visual before you as well. All right, let's encompass teen pregnancy. So teen pregnancy and childbearing are associated with increased social and economic costs. Pregnancy and birth are significant contributors to high school dropout rate among girls. The CDC reports 50% of teen mothers receive a high school diploma by the age of 22, compared to women that do not have a birth in their high school at 90%. Children of teenage mothers are more likely to have lower school achievement and drop out of school, have more health problems, be incarcerated at some time during their adolescence, give birth as a teenager, and face unemployment as a young child. There are disparities by race and ethnicity. Social detriments are conditions and environments such as where people are born, live, work, play, worship, function, and quality of life outcome and risks. Some impactful detriments of health that impact higher teen birth rates are high unemployment, low education, and low income levels of the actual teen's family. Health equity comes into play as well. There are health inequities with respect to social position, race, ethnicity, gender, religion, sexual identity, or disability. As a nurse practitioner, I do my best with helping to close that gap. And even as a provider and educated woman, I too have experienced inequity because of my race. However, can we help reduce these? How can we help reduce these inequities? We can improve access to quality care, particularly in this topic with reproductive health services, including contraception and sexually transmitted infection services. This plays an important role in supporting the health and well-being of adolescents as we promote health equity. We can help improve life opportunities and health outcomes of young people and reduce economic cost of teen childbearing. So let's talk about sexual assault and rape. Rape, sexual assault, and sexual abuse can have different legal definitions. In general, rape, sexual assault, and sexual abuse are forms of violence in which there is sexual contact without consent, including vaginal or anal penetration, oral sex, or even genital touching. In the US, the legal definitions of rape and sexual assault vary by each state. Each state uses these terms interchangeably. Anyone can be a victim, no matter their gender, sexual orientation, or age, but certain groups of people are more likely than others to experience sexual assault in their lives. Women, especially women of color, LGBTQ identified people, and people with developmental disabilities are more likely to experience sexual assault over the course of their lifetimes. Sexual violence doesn't happen in one single way. There doesn't need to be a weapon involved, and the victim doesn't have to have fought back, scream, or repeatedly say no in order for it to count as an actual rape or sexual assault. Most assaults don't happen by strangers in dark alleyways. Often it's somebody that the victim knows, or even a romantic partner. If you or someone you know has experienced this type of violence, you are not alone and there is help available. If you've been raped or assaulted, you don't have to go through this alone. Remember, it's not your fault. You may be feeling a range of emotions, but whatever you feel, know that what happened to you wasn't your fault. It was 100% their fault. Don't blame yourself for anything you did or didn't do. Make sure you are safe. Get to a safe place or call a friend who can help. If you are in immediate danger, call 911. If the person who assaulted you is a family member or someone you know, tell someone you trust what happened. Once you're in a safe place, don't do anything to change your appearance. You don't have to decide right away if you're going to talk with the police about what happened or press charges against the person who assaulted you. But just in case you do, it's important that the doctor or nurse you visit can collect any evidence that might be on your body. So don't take a shower or bathe or wash off any parts of your body. Also, if you can, don't go to the bathroom, comb your hair, eat, smoke, drink, or take any drugs. If you change your clothes, take the clothes you were wearing during the assault to the hospital or police department in a paper bag. Get medical care. If you have injuries, or if you want to have a rape kit collected, if you're worried about being exposed to HIV, there is post-exposure prophylaxis, which can help prevent you from getting HIV after being exposed. You need to start the treatment within 72 hours. If there is a chance that you could be pregnant, consider taking the morning after pill, which is emergency contraception. You need to take it within 5 days after the unprotected sex for this to be effective. And if you're worried about STDs, it's a good idea to have some STD testing completed. Find support. Dealing with the aftermath of rape or sexual assault can be overwhelming, but you're not alone. It may help to talk to a trusted friend, family member, or an actual counselor. Seek out resources. So there is a resource called RAIN, Rape, Abuse, and Incest National Network, and they have a 24-hour, 7-day-a-week support line, which you can actually reach by phone or chat. And then if you want to talk to the police, so sexual assault is actually a crime and you have the right to report and press charges if you want to. You can call them yourself, or the rape counselor can help you make that phone call as well. One thing for you to understand, the only time that If you report this to someone and you are younger than the age of consent in your state, and you tell someone like your teacher, your counselor, your doctor, these individuals are all mandated reporters. This means that they have to call the police no matter what you want them to do according to the laws to actually protect minors. Sexual harassment. So the EEOC says that this is unwelcome sexual advances, requests for sexual favors, and other verbal or physical conduct of a sexual nature. Sexual harassment, when this conduct explicitly or implicitly affects an individual's employment, it unreasonably interferes with an individual's work performance or creates an intimidating, hostile, or offensive work environment. So social coercion entails a sexual advance and makes the condition of employment or education for students contingent upon sexual cooperation. There's also gender harassment. This is by far the most common type of harassment. It refers to a broad range of verbal or nonverbal behaviors not aimed at sexual cooperation, but they convey insulting, hostile, and degrading attitudes about members of one's gender. This gender harassment is further defined as two types. So you have sexist hostility and you have crude harassment. Sexist hostility is a form of gender harassment for women, include demeaning jokes or comments about women, comments that women do not belong in leadership positions, they're not smart enough to succeed or be in a scientific career, or sabotaging women. But crude harassment is sexually crude terms, which is one referring to a female coworker as a slut or using the derogatory term for vagina. Both women and men can experience all types of forms of sexual harassment, as I have discussed. With respect to responsibility, the organization has a responsibility. Municipalities, schools, counties are responsible for creating a workplace that's free of sexual harassment. The law defines that this responsibility is the employer's duty to exercise reasonable care to prevent and promptly correct harassment. So management's responsibilities. Managers are actually responsible for their own behavior and to some extent the behavior of their work group, as well as upholding and implementing the employer's policy. Management should be aware that they could be held personally liable for any sexually offensive behavior that they exhibit toward an employee. Managers are often unaware that an employee finds a particular behavior offensive because the employee is reluctant to speak up due to the power imbalance. However, it's just that power imbalance that increases management's responsibility and liability. If a manager takes any tangible work action, either to the benefit or detriment of an employee because of sexual behavior, their liability increases further. So with respect to employee complaints, when an employee actually makes an complaint, the organization is obligated to investigate. The management should reassure the employee that the employer's policy provides protection from retaliation and that confidentiality will be protected to the extent possible. All right, so parent communication. So when is a right time to start that discussion? So starting the discussion, it's a good idea to start laying down the groundwork for these conversations long before the onset of puberty. The more frequently and frankly sexual matters are discussed, the easier and even more open such discussions are likely to be as you both grow comfortable with talking about it. Let's face it, we're all embarrassed to talk about sex with each other. The easiest way to start is to be real with your adolescent. This is really hard for me to talk about, and it was hard for me to talk about with my dad when I was your age, but it's important to talk about, and we have to talk about embarrassing things sometimes. Keep reminding your child that you are in her corner every step of the way. Never let them forget your love is unconditional. Tell them, I'm here with you. I love you. I will always be here with you, no matter what, all through this. Yes, it's much easier said than done, but nonetheless. So keeping the channels open as your child matures, physically, mentally, and emotionally, opportunities will emerge from making regular discussions about sexually part of continuing conversation. Obviously, changes in your child's body and puberty begins are crucial markers for such conversations. One area that should receive particular attention is urban myths, bits of false information that everyone knows, passed along from adolescent to adolescent, and even from generation to generation. Don't be surprised to find that your child has heard some of the same myths and misinformation circulated during adolescence. Make clear, for instance, that oral sex is not without risk, that unprotected intercourse without ejaculation is not effective birth control, and so on. It's very important to get the facts straight from the start and share the facts with your child. That builds trust, and that trust is critical to guiding your adolescent through these challenging times. In particular, be specific and accurate about the risk of pregnancy, the effectiveness and the limitations of different types of birth controls, and talk to them about the variety of sexually transmitted diseases. I can recall for myself, my 19-year-old did not want to get the Gardasil vaccine, and it wasn't because of the anything to do with the protection of it. It was because that vaccine is very painful. It is a very painful vaccine. Out of all of the vaccines that he's received, he said that was the most painful. And for his age group that he is in, this is when you had to get 3 shots. Now you only have to get 2 of them. So, you know, each time we had to, after the first time, you know, like, Mom, why do I have to do this? I pulled out my phone and I actually showed him pictures of human papilloma virus genital warts. And I talked to him about the different types of cancers. And he was like, okay, I want to get it. So sometimes, you know, letting them know and giving them that information and showing them that information will help them be able to make better decisions. So impacts of nurses and providers. As nurses and healthcare providers, we care for adolescents in a variety of settings: communities, schools, public health, acute care clinics. We provide many opportunities to improve adolescent sexual and reproductive health, with a goal to reduce unplanned pregnancy and sexually transmitted infections. Adolescents face a variety of critical sexual and reproductive health challenges, such as unplanned pregnancies, STIs, including HIV. While these conditions are preventable with the appropriate access to adequate sexual and reproductive health care, including both preventative counseling and treatment, adolescents can lack easy access to condoms and other contraception as well as counseling. Thus, sexual health challenges go unaddressed and often can lead to serious outcomes. The most appropriate time for initial preventative sexual and reproductive health counseling is before an adolescent's first sexual experience or first experience of sexual intercourse. Literature calls this their sexual debut. However, this type of counseling is lacking, which can contribute to the consequences previously discussed. There is a call for improvement. The United Nations Convention on the Rights declared that adolescents across the globe have the human right to receive sexual and reproductive health. The Society for Adolescent Health and Medicine issued a position paper that has called for improvement in adolescent sexual and reproductive health care. The goals include that adolescents should have universal access to comprehensive sexual and reproductive health information and services that are evidence-based, confidential, and developmentally appropriate and culturally sensitive. Healthcare providers should have the knowledge and skills to deliver sexual reproductive health services that have been proven effective in clinical settings. I believe that further research is needed to identify best practices and the methodology that is effective to implement these strategies to prepare nurses to provide health education across all settings. So understanding pubertal changes and the challenges that our young women will encounter in life will help parents, educators, providers, and the community truly understand how to educate, prepare, and help our young women be mentally and physically prepared, but set them up for success. Knowing is key in life. I hope that this information has been helpful. It takes a village to raise a child. Parents can be supportive and listen patiently. Having your support and educating your child makes a huge difference. Let your children learn from you about their self-worth, social norms, preventing teenage pregnancy, and understanding the complexities of life. Thank you to my husband, Gustav Dowling III, for always being here and being my voice of reason. And this is dedicated to Dr. Benny Marshall, Dr. Scheherazade Taylor, and Dr. Lenora Horton, impactful women in my life that took the time to not only educate me, but empower me to be the professional that I am today. Last but not least, in the quest for evidence-based practice in education and practice, my confidant and colleague, Dr. Yvette Lowry.
Wow. Thank you so much. Thank you so much. That was fantastic. I mean, you left us with a ton of information. All right. So in the interest of time, we actually do have some questions. And
Oh, yes.
Yeah, so there are some questions posted in the chat. So I'm going to take the first one real quick. Looking for the first question.
Let me go. Let's see.
All right. So do you see weight gain, even overweight, before puberty? I have parents who feel, I think this is one of our nurses. I have parents who feel like the girls will have a growth spurt and lean out. Do you see this in your experience? And is this notion okay to support?
I do see this in I absolutely do see this in my experience. I will tell you, because we talked about how that body fat actually increases and their lean body mass actually decreases. I wanted to put a picture. I forgot to put a picture. So my daughter is 11 years old. She always was very lean. And now that adipose is starting to come into play for her. She's at about 10 or 3 right now. And she's, got some hips, got some thighs. We don't like to see that, but it is what it is. They're going to go through their development. But just in this school year, she's grown 2.5 inches and she's starting to lean. It's starting to lean back out. So it does start to correct this stuff, but still the same. What I would actually encourage you to is to make sure that your child is engaged in, if they're not in a sport, because I keep them in sports all year long, make sure that they are exercising. So on a day that she doesn't have practice or a game, she actually goes out and hops on the Peloton or my row machine and exercise. We have to make sure, because it's not the same from when we grew up, where we didn't have access to the internet or social media. You didn't have a choice but to go outside and play. And so, that's the differences that I think that we see from when we were growing up versus with the children. So I definitely do see that. I do think that she will lean out based off of that information that we just talked about, but do keep the child active.
Oh, wonderful. Thank you very much. There's another question from Mrs. Afoma Babatunde, one of my high school alumni, peeps. Is it normal for teens to vomit during periods? Is this something that they will outgrow as they get older? If not, what can be done to avoid the discomfort of cramping, nausea, and vomiting?
That's not normal for you to be vomiting during your actual cycle. I recommend for the parent to make an appointment with the child's pediatrician, and they may need to have a referral to a gynecologist just to make sure, let them check overall hormones and see what all is going on. Cramping is normal. And of course, the bleeding, but not vomiting. I've heard of definitely having, you can get a little bit of nausea maybe those first couple of days. Everybody's PMS symptoms are different. We all experience different things, but see a pediatrician and have them evaluate that just to be on the safe side.
All right, wonderful. So Dr. Dowling, even though this question isn't posted, I have a question for you.
Yes.
From some of the discussions I've had in several different groups in Nigeria, our culture and morals are very strong, and these are conversations that I guess as generations change, we're sort of easing into. So two-part question. What is the appropriate age to start talking to children about sex? One. And two, whose primary responsibility is it? Is it the teachers who teach the students in school or the parents?
The primary responsibility goes to the parents, right? Because depending upon what state you are in, those conversations may not happen. I reside in the state of Florida. The only education that we are, that the school system provides here is about actual reproduction. There is no education about contraception. I don't even think that my son Sebastian told me that they didn't even talk about they didn't talk about sexually transmitted diseases at his school either. So that's going to be the parent. And so the CDC says that we should actually start having these conversations before they actually hit puberty. And you have to, I can't say that it's a set age because everybody's child is different. I have my daughter that's 11. I have a son that's 12. And then my 19-year-old. My 19-year-old, the most clever one, we started having those conversations when he was 7, 8 years old. And always been able to have those conversations with him without, there's no embarrassment. The same with my middle son, a little bit of embarrassment with him, a little bit of blushing, but he wants to know. My 11-year-old, my daughter, she's so innocent. But I started having these conversations with her because she started to develop breast buds at the age of 9. Okay, I got to go ahead and start, even though she's innocent. And when I say innocent, I'm speaking from her emotional standpoint. She's all about, I can't say doll babies, but just still kid stuff versus her brothers were more, I guess, ahead of their time is what I'll say. But I had to start talking to her about this. Why do you have to start talking to your child about this? You have to start talking to your child about this because one of the things that I noted was children that develop sooner, which actually Black children develop sooner than Caucasian children. They start development at about 9.5 years old, where Caucasians start at about 10.3, can start. The trend is different for everybody, but traditionally we start to develop beforehand. And because of that early development, that predisposes them to sexual abuse or sexual encounters earlier than other individuals. You want to have the conversation so that you can talk to them about if someone is being inappropriate with them, what the norm, what normal behavior is, if someone is asking to look at something. And I will say, even for her, at the age of 7, her pediatrician had already started those conversations with her. Before me, her pediatrician looked at me and, is it, yeah, sure, it's okay. I want her to know. She told my daughter, no one should be asking you to look at your privates. I'm going to ask for permission today to look at your privates while I do your examination. I'm going to ask for permission to look at your breast today while I do your examination? So those conversations have to start early because we have to think about sexual abuse as well. It doesn't always come from outside. Sometimes it can come from within your family and you are not cognizant about it. So arming them with that information so that they know that something wrong is happening, because if you haven't talked to them, then they don't know that something wrong is happening.
That is wonderful. Thank you. So we'll be able to take, a few questions or comments. If you have a question or a comment, please, you can put your hand up and I'll unmute you. But before we do that, I just want to make an announcement. So one of the reasons why we actually thought this lecture was very important at this time was because some of our nurses in the rural schools that we participate in secondary schools in Nigeria realized that some of the young girls were starting to go through puberty and starting to see their periods. Their parents hadn't talked to them about it. They'd spot and bleed in school. They were embarrassed. So our nurses started talking to them about it. So that's one. But also there was a challenge because they couldn't afford pads. So one of our staff members, Mr. Olumide Obe, he went to social media and just posted that, he wanted to buy pads for these young girls. And a lot of people, donated money, to buy pads. And we actually recognized that that was a great opportunity. So we're actually, making a call, if you're interested in supporting these young women, these young ladies in these rural public schools, please reach out to me, reach out to any of our members for Help for Nigeria. Anything you can do would go a long way, but we actually want to support these young ladies as they go through puberty with pads. Something as simple as that, unfortunately, is something we still struggle with in Nigeria. So, all right. Do we have any questions, any comments? Okay, so Dr. Ogunjimi, I see your hand raised. You can unmute yourself and ask your question.
Oh, sorry. Hi, everybody. Oh, Dr. Beam. So question for you. I do know that you mentioned the donation aspect of it. Is there like a website or where we can kind of like distribute to where people can directly put money in, or I kind of like put a donation in? You want to put that in the chat box, or you also want to kind of like email that with the recording?
That is an excellent question. I'm putting our website in the chat. You can also reach out to me directly. Once the recording becomes available, I will share it with with the distribution list. And from that, you can also reach out to us and let us know. But thank you for that question. I mean, every little bit helps a lot.
Yeah, and I did like the idea about, I like the topic really much, and I like the way that you also mentioned the cultural aspect of it, because sometimes women, mothers in our culture, because I'm from Nigeria as well, they are not comfortable discussing sexuality with their kids, but we have a lot of liberty with our teachers. I mean, good teachers who are able to pass those information across to children. So what I will encourage is, as much as possible, the nurses are already doing a good job, but, encouraging that education in school. And I think your organization is doing an excellent work already in terms of, providing those kind of support for those little girls. So that's all I'm going to say. I think that cultural aspect is very important, and us realizing that they may not necessarily get those information from home, but being able to give them those information outside of their homes will also go a long way to empower them.
Thank you very much, Dr. Ogunjimi. I appreciate that. Yeah, our cultural values and morals are very strong, and we just, believe our children are completely innocent, and as much as we want to believe that, if we don't start the conversation with them, I mean, there's significant influences, social media, and even their friends, so I mean, I think that's an important role we need to play. Dr. Jalade, you have your hands raised.
Okay, sorry, I was having trouble unmuting there. Thank you for bringing this point up. For me, I have no girls, I have all boys, but now I have grandchildren, and my granddaughter actually is now 12 years old. So this is very, very appropriate for me. The last person that commented is not only in Nigeria. Somebody like me, I'm an older generation Nigerian. I lived abroad for so many years. The discussion of sexuality, we bring it with us. I have friends that have girl child, boy child. We don't feel comfortable talking about it. It's a cultural thing that cut across every continent. So we need to actually do better with our education and our exposure. Yes, it's good for schools to bring up the conversation. I think Dr. Beam and all my esteemed colleagues on the line, we need to figure a way to start the education at home. How do we get comfortable and start talking about this? Because our kids are they need to know this information, not from the social media or from their friends. So this is something that we need to do. I love all those kind of things. Remind me when I was in my FMP school 100 years ago, and I'm like, when Bella gets home today, we're going to have a talk. So that's my granddaughter. We're going to have a talk today about this whole kind of thing. I sort of like forgot about it until when you brought it up, Dr. Dowling. Thank you so much.
No problem. And as you guys are talking about this, for me, my mom did not talk to me about anything reproductive with respect to menstruation. That was something, thank goodness. I mean, as I told you guys before, I'm from Virginia, so we have an awesome school system in Virginia. I learned about it from there, so I knew what to do once that did happen. But there was no talk, from my parent about protection, condom use, contraception use, which is very important since my mom had me when she was 15 years old. So it's definitely a conversation that you want to have. If you look over there in the chat link, the last one that I posted is a Planned Parenthood tool for parents with how to broach, the last actual two of them, how there are different resources for how to broach these conversations with your kids, just for to help you out.
And I think Dr. Julian posted something here, so often parents are not equipped with the correct information or language to discuss with their children. So thanks for this presentation. What I want to take out of that comment is we're emphasizing and overemphasizing the fact that parents should have these discussions. Parents, please don't start the discussion without doing some research and actually trying to get accurate information, because if we do that, we'll interact with our children based on our experiences of what we've heard or what we also see in social media or in society, so it might be worth actually doing, and there are lots of resources here, so identify a resource that would help broach the conversation and also provide, lots of factual information that you'll be sharing with your child, so do a little bit of research first and ensure you're comfortable with the, with the content, with the material before you have the conversation. So thank you for that point. I think that's very important because some of us may, our hearts may be in the right place. We also may be trying to do the right thing, and we could also then potentially spread false information. All right. So once again, Dr. Dowling, thank you so much. You did a fantastic job. You know, I mean, I speak for everyone. And if you look in the comment section, I feel everyone's also providing lots of kudos. Thank you so much for not only taking the time, but also for preparing and for delivering this excellent lecture. So we truly
My
appreciate your
pleasure.
time. All right, so we've recorded the lecture. We'll have it distributed so everyone has access to it, and please use it as a resource as you engage your children, or for us healthcare professionals as we engage our patients or parents. You know, so once again, from myself and from everyone at Health for Nigeria, thank you so much for taking the time. We really, really appreciate it. Thank you.
With only 35,000 doctors. That is one doctor to 53,000 Nigerians. The healthcare allocation is 3. .5% of the GDP, $5 per person per year. WHO recommends 5%. This explains why our healthcare system is the way it is. Patients are not being attended to. Government hospitals are overcrowded. Health workers are overwhelmed. Private specialists are unaffordable. Something has to be done. To tackle these issues, Health for Nigeria believes the healthcare sector needs an inspired and well-motivated group of young leaders to canvass and act for excellence in the healthcare standards of Nigeria. Our team of healthcare professionals and leaders are committed to improving access to healthcare for all Nigerians, especially our children. With our nurses in all basic schools in Nigeria, we give children basic health education and support across Nigeria. Health for Nigeria, health equity for all Nigerians. Nigeria, a nation with a population of over 200 million people with only 35,000 doctors. That is one doctor to 53,000 Nigerians. The healthcare allocation is 3.5% of the GDP, $5 per person per year. WHO recommends 5%. This explains why our healthcare system is the way it is. Patients are not being attended to. Government hospitals are overcrowded. Health workers are overwhelmed. Private specialists are unaffordable. Something has to be done. To tackle these issues, Health for Nigeria believes the healthcare sector needs an inspired and well-motivated group of young leaders to canvass and act for excellence in the healthcare standards of Nigeria. Our team of healthcare professionals and leaders are committed to improving access to healthcare for all Nigerians, especially our children. With our nurses in all basic schools in Nigeria, we give children basic health education and support across Nigeria. Health for Nigeria, health equity for all Nigerians. Nigeria, a nation with a population of over 200 million people, with only 35,000 doctors. That is one doctor to 53,000 Nigerians. The healthcare allocation is 3.5% of the GDP, $5 per person per year. WHO recommends 5%. This explains why our healthcare system is the way it is. Patients are not being attended to. Government hospitals are overcrowded. Health workers are overwhelmed. Private specialists are unaffordable. Something has to be done. To tackle these issues, Health for Nigeria believes the healthcare sector needs an inspired and well-motivated group of young leaders to canvass and act for excellence in the healthcare standards of Nigeria. Our team of healthcare professionals and leaders are committed to improving access to healthcare for all Nigerians, especially our children. With our nurses in all basic schools in Nigeria, we give children basic health education and support across Nigeria. Health for Nigeria, health equity for all Nigerians.
All right, thank you so very much. So we'll be shutting down now. Thank you and do have a great day.